and I hold the CAW Guinea Chair in Social Justice and Democracy. It's a very long name, at Ryerson. And Guinea Chair is co-hosting this meeting with Street Health, Ontario Health Coalition, Ontario Coalition Against Poverty, and Sistering. And so I'd like to welcome you all here to Ryerson. It's great to see such a big crowd on a Thursday night. Even before I feel like it's before the political season's gotten going, but I know it's not. It's just how I feel. I get kind of buried in my work. To say that we want to have a really good discussion today. And we have 4 very good, excellent speakers from different organizations. And our topic, as you know, is poverty and healthcare. And we're going to look at the relationship between poverty, income security, and health. And I'm personally very excited to see this kind of gathering, because I think more and more what we're seeing is that where the most powerful and successful movements are happening today is in spaces of convergence, where different movements come together and work together on common issues. So I think it's very exciting to see this initiative and to see such people. And I recognize some of you who are activists, in churches and anti-poverty groups and immigration groups and so on, as well as in the Healthcare Coalition. So I think it's a really exciting moment, and I'm not going to say much more than that. I want to introduce our speakers. They're each going to speak for 5 or 7 minutes, and then we'll go over to you. And if you have questions or points you want to raise, I'd ask you to keep it short so that we can have lots of interaction. And we'll use a roving mic in the audience if we wind up needing a mic. And we'll try and finish by 9, eh, Natalie? By 9, yeah. Just finish by 9. Okay, so without any further ado, I'll introduce our first speaker, who is John Clarke. Probably most of you know John. He's the founder of the Ontario Coalition Against Poverty. He's a very well-known social activist, and I can thank him for the fact that because of him, I spent an hour and a half on the stand testifying in a court case a few years ago, which was a great challenge. So. But John is very well known in Canada. He's been a leader of OCAP, which has been one of the most effective anti-poverty groups, direct action group, that's really put light on the issues of poverty and poor people in this city now and in this province for a long time. And they, one time were very targeted by the government, but they lived through that and continue to do just excellent work right across the province. So please welcome John Clarke.
I'm going to speak, I suppose, about the income and health gap side of things. And the key question that I wanted to focus in on is the issue of income support systems, and particularly social assistance rates, the level of income that are paid to the hundreds of thousands of people in this province who live on social assistance. And those rates have an enormous impact in terms of wage rates. They are a major question. When Harris cut social assistance rates by 21.6%, with no increase in inflation, this eventually became something like a 40% reduction in income. The results were fairly predictable. I don't think it requires any great learned sense of the medical sciences to understand that if people are unable to afford adequate nutrition and are able to afford decent and secure and safe housing, this can only have a disastrous impact in terms of health. And the Ministry of Health is awash in studies that point to that very conclusion, although it doesn't seem to make it over to the Ministry of Community and Social Services with any great effectiveness. Now, when people address questions of poverty and health and talk about social assistance rates in particular, you often hear people say something to the effect of, it does not make good economic sense to keep people in poverty. Why do they do that? It would be a cost-effective thing to ensure that people have adequate income. I think that's true, but it rather, as an analysis, misses the point. Because poverty in this society actually serves certain interests. Keeping people in poverty doesn't just happen because there are some people at the top who are neglectful or mean-spirited. It serves a very, very definite purpose. When Harris came to power determined to slash social assistance rates, he had a particular object in mind. I remember looking into things, reading about a group of US economists in the 1970s who were looking at the question. They weren't progressive economists, and they were looking at the question of why it was that in the midst of a recession, unemployment rates were not coming down. And one of them actually penned these words. He said that the existence of unemployment insurance and welfare programs have made unemployment insufficiently terrifying. And that mechanism, I think, was at work when social assistance rates were cut by the enormous amount. Now, there was an important test of the theory, as it were, when we came across something known as the special diet, a means by which people on social assistance could have a medical provider diagnose their need for up to $250 a month extra. And what was illustrative in terms of the theory I'm advancing was that the provincial government went into a veritable frenzy to try and ensure that the special diet was closed down. Because you now had a situation where instead of getting approximately $550 a month at that time for a single person, an extra $250 was available to people. And the terror that they spoke of in terms of unemployment and dependency was significantly reduced by that. You're in a situation now where people can actually not have to choose between substandard housing and the threat of losing it and eating adequately for themselves and their families, with all the effects that has on health. So there was an absolute frenzy to move against the special diet and close it down. So from that, I think, flows something very, very important, a very, very important consideration. We're speaking in a week when McGuinty has gone before the media and suggested that poverty reduction has to be delayed indefinitely because the economy is going down and poverty is going to increase. Rather like arguing that we can't give you any medicine until you get better. But in that situation, in that context, I think we have to understand that the struggle against poverty, which is to say the struggle for decent health and human dignity, requires that people recognise that we are not dealing with good faith operators in governments, that we are going to have to organise not to show them the errors of their ways and prevail upon their consciences, but to actually build the kind of social movement that is capable of forcing governments to provide for people's basic needs. And if we're not able to do that, then decent income and people's basic health are going to be increasingly compromised in this society. Thank you very much.
Laura Cowan. Laura is the Executive Director of Street Health, another organization that's been incredibly effective in making sure that poverty has been on the agenda in this province. I remember I remember lots of things that Street Health has done over the years, and it hasn't been easy in Ontario to keep poverty on the agenda, and I think these are two organizations that have really worked hard to make sure that that happens and that poor people have a voice. She's a registered nurse who received her BSCN at Ryerson, so she's a Ryerson alumni, and after working for several years in women's health and related services, she became Executive Director of Street Health, where she's worked for the last 13 years. So please welcome Laura Cowan.
Just a little bit about Street Health for those of you who don't know. Street Health offers nursing and other programs and services on an outreach basis to homeless men and women in downtown Toronto. We're located not far from here at Dundas and Sherbourne, in a neighborhood that's really, I guess, awash with hostels, homeless shelters, and drop-ins, as well as lots of poverty. Street Health also does a lot of advocacy. We're engaged in a lot of advocacy around the need for affordable housing, a livable income, as well as access to health care. So obviously I'm going to speak today from the point of view of homelessness and healthcare and access to healthcare. So currently there are about 32,000 different people who use shelters every year in Toronto. When the city conducted its street count in April of 2006, there were over 5,000 people that were either living in shelters or on the street at that time. But of course that doesn't count the thousands of people that are couch surfing, that are living in substandard housing, that are living in crowded conditions. So that the 5,000 plus people that were counted are really sort of the tip of the iceberg in terms of homelessness in Toronto. Street Health conducted a survey of 368 homeless men and women in Toronto, and we were looking at their health status and their access to health care. The results were extremely troubling and basically confirmed what frontline workers see on a daily basis. That despite our supposedly universal healthcare system, homeless people are having an extremely difficult time accessing adequate and appropriate health care. For example, some of the stats, I'll just run them by, some of them by you very quickly. If you want the full Street Health Report 2007, it's on our website, which is streethealth.ca. For example, 59% of the homeless people that we surveyed did not have a regular family doctor, and compared to the 9% of the general population in Toronto who do not have a family doctor. In fact, the hospital emergency department was the most frequently used source of health care for over 50%, 54% use the ER on average 5 times a year. So that was their usual source of health care. Many people reported as well that they couldn't access mental health care as well as addiction services that they really needed. Homeless people face major barriers when accessing even the most basic of health care. 28% of the survey respondents had been refused health care based on the fact that they didn't have a health card. Discrimination was also a frequent focus of the respondents, talking about their experiences that they received on the end of healthcare practitioners, being refused healthcare, being disrespected and talked down to by many healthcare professionals. And if you look at sort of the overall results of this, you know, it really, this is poor treatment, obviously, and poor treatment like this, when faced by a homeless person, means that they're not getting the care that they need, but in fact, sometimes not getting any care at all. Many of the people that we spoke to said that they were too busy, actually trying to just survive on the street, trying to get housing, a place to stay, shelter, trying to get food, even to worry about health care. And so this speaks again to the needs of additional programs, as well as to, of course, for more affordable housing. Our study compared the results of another survey that was done by Street Health in 1992. We did a very similar study, and where we could compare data, we found that the results were the same or were worse than in 1992. The health status and access to health care that people were experiencing. As John has alluded to, you know, a lot of what we're seeing today, a lot of what homeless people are facing is a result of social and political policies that have been in place for the last 15 years at least. Although have been marginal increases in social assistance rates, nowhere near where they need to be. And again, as John stated, actually 46%, welfare recipients still receives about 46% less in real terms than he or she did in 1992, so appalling. Again, and we saw this in our study, 50% of the people that we spoke to are trying to live on less than $400 a month. And more than half, 52%, were not getting any welfare, disability, or any kind of government support. And we were quite shocked by that, in fact. So our report makes a whole series of recommendations, and I'll just mention a few of them. And they're aimed at trying to improve the health of homeless people and also eliminating the root causes of homelessness itself. So first of all, people need an adequate income to be healthy. We recommend increases as well to the minimum wage and social assistance rates, and also improved access to benefits like ODSP, Ontario Disability Support Program. People need adequate housing and to stabilize their lives, to be healthy. And we also need to enhance services for homeless people that already exist. For example, so I have two examples. If I could just talk about this, the need to increase awareness and capacity among family doctors about the unique needs of homeless people. Again, this is to combat this discrimination and rejection of people who are homeless. And hospitals really should be required to do mandatory training with their staff and educate staff around homelessness issues. We think that there should be an expansion of primary care models like community health centers, and also sort of walk-in, drop-in hours for homeless people so that appointments aren't required. This is a huge barrier. And lastly, we want to build on existing programs to help homeless people replace and store their health cards and any other ID that's required. So again, check out the full report on our website, which is streethealth.ca. Thanks.
Thanks so much, Laura. Our next speaker is Doris Grinspun, who's the Executive Director of the Registered Nurses Association of Ontario. And it's just great to see someone from the RNAO here, because I think, the more organizations, mainstream organizations and professional organizations that speak out around these issues, the more likely we're going to have action on them. It's a professional association representing registered nurses in the province of Ontario, and its mandate is to advocate for healthy public policy and for the role of registered nurses. Doris assumed this position in April 1996. Please welcome Doris Grinspun.
I need to say first thank you for introducing our organization as mainstream, because government thinks we are extreme. So thank you for that introduction. You may want to speak with the various political leaders, both provincially and federally. But let me ask you, before I launched into speaking things, how many of you know what is social determinants of health? Most of you. So I don't need to speak to people that know. So instead of that, for the few that didn't put the hands up, I'm referring to income distribution, housing, education, those type of things. And you simply cannot be healthy without that. So instead of speaking about social determinants of health and how they are linked to health outcomes, I'm going to talk about politics. Because it will be terrible to leave today this forum not speaking about the politics of poverty, some of which was pointed out. It is a strategy. I don't know how many of you saw SICO. How many of you saw SICO? Well, I actually would ask all of you to see SICO, because in that movie, Michael Moore gave the best, actually not him, but this fellow from the UK that was one of the leaders of the labor movement in the UK, gave the rationale for why governments keep people poor, because they keep them, as he said, in their shackles. And they keep them with the heads down and not being able to react to what's happening around them. And that is what's happening in this country. So while the Premier said that we will need to delay the Matthews agenda on the poverty strategy, I think we all need to stand up and make phone calls tomorrow morning, if not tonight, and say we can't afford it. Because we can't afford, in a country as rich as ours, and in a province as rich as ours, to leave people behind. And because this is a Premier that actually promised not to leave people behind. So please make those phone calls. But let me speak not only about the agenda of Ontario, where we have, just so you know, 1.7 million people living in poverty in our province, and where we have 1.2 million people that earn less than $10 an hour. let me speak about the federal elections, because actually we all need to get out there and vote. And because I am mesmerized, if not fascinated, if I just would look at this intellectually, I quite frankly will be fascinated. But instead I'm scared to death of what will happen to this country if we keep seeing the polls the way they are. Because the future of this country, not only on the area of poverty, but on the area of safety, on the area of healthcare, on many other areas, is at stake. And we all have a responsibility to take action on that, to get informed and take action. So on that note, at the back of our room, I left the platform of the nurses of Ontario, which deals with social determinants of health, environmental determinants of health, Medicare, nursing, and of course, the need not to cut taxes at this point, but actually to improve the social services. So that's at the back of the room, and next week we have a press conference, and in October we have a session with all candidates, co-sponsored with York University, etc. But it is critical that we don't let politicians, federally, provincially, or anywhere, to get away with the fact that it's the economy that is making them not to move with agendas for poverty, because that's a simple lie. That is a lie. It is not true. Because anyone that understands the link between poverty and between health will actually invest in poverty at the time of a downwards in the economy and not leave more people behind, because we all will end up paying for it in illness. The link between poverty and illness is absolutely clear, not only in low birth, even before a person gets born, but also later on in life with heart conditions, for example, and many others. So the links are there, politicians know them, and what they need, and I will concur with my colleagues, is to simply force political will. For once we have a government here that said we'll take this agenda on, let's make sure they move on with the agenda and no excuses are used. And at the federal level, let's make sure that we put in place a person that understands what the majority of Canadians not only need, but want, and not the majority that have the money.
Thank you, Doris, very much. The next and the last speaker, this is great, everybody's keeping to time, it's wonderful. The next and last speaker from the front is Natalie Mehra, who I'm sure many of you know. Natalie is kind of a force of nature. She's traveling constantly all over the province to organize, and the Ontario Health Coalition, she's executive director of the Ontario Health Coalition. They have over 70 local chapters and 400 organizations that work with them across the country. They're the best, or I know across the country, the best organized health coalition, and every other health coalition in Canada looks to them as an example of organizing. So please join me in welcoming Natalie Mehra.
Just as the plan to dismantle the income support programs in Canada and in Ontario was very clearly planned, very clearly coordinated, ruthlessly executed, and very effective at creating greater inequality, so too is the attack on Medicare. So I'm going to focus my comments today on the attack on Medicare. I think most of us know about the social determinants of health, and so therefore the link between poverty and ill health, but maybe not so much the link between the design of the health system itself and poverty. So looking the other way. And so maybe you can hold up your hand. Who's heard here that health spending is out of control? Who's heard it? Right? Anyone know how much we spend per person on health care? Any idea?
$2
Per year? No idea. This is the same. I mean, I speak probably just about every day to multiple groups of people. There's not a soul who actually knows how much we spend on health care. It's about $3,000 a person a year in Ontario, but nobody knows that. But everyone has heard that health spending is out of control. Just part of the very concerted, very carefully messaged, very carefully framed attack on Medicare. Medicare is the largest social transfer in the country. By that I mean it's the largest collection of taxes that's transferred out or redistributed to everybody in services that are free at point of access. And the idea of Medicare, therefore, is that it's a redistributive program. The idea was you couldn't afford access to health care under the private insurance system or under no insurance system as predated Medicare. And so in order to provide access to health care, really what you needed to do was pool income, and as long as you have a progressive tax system, as long as the wealthy pay more than the poorest in taxes, and you're pooling from the rich, largely from those who are able to pay and transferring that to those who are not able to pay through free access to services. That's how all of the large social transfers work that were created prior to World War II, such as education, or after World War II, such as health care, pensions, unemployment insurance, and so on. And so Medicare across the country is a $130 approximately billion program, of which 65% is public spending. So about, say, $80 billion collected, $80–90 billion collected in tax money and then transferred back out in free access to services. Medicare, therefore, really isn't a cost, it's an investment. And it's an investment that we all benefit from. In fact, everybody in Canada actually receives more out of the health system in their lifetimes, and most of them at the end of their lifetimes, the last 2 years of your life when you use the most of the healthcare system, than they put in, except for the wealthiest 10%. The people who, of course, are very much behind the campaign to dismantle Medicare. So up until the mid-1980s, the large social transfers in this country, had worked to some extent to mitigate the inequalities that are dished out from the marketplace. So from employers, in inequalities in pay and access to wealth and so on. Not that it was perfect, by far it was not perfect, but it was, they were working still to mitigate inequality, and inequality actually had been shrinking for some time. After the major counterattack, with the Thatcher era and so on, we started to see a real increasing gap, or the growing gap in income equality in Canada and also across other countries. Up until the mid-1980s, there was a rather large social consensus in Canada that there should be a public universal Medicare system. And that would have crossed the NDP, the Liberals, and even the majority of the Tories at that time. And it's a reflection, I think, in part of the strength of the social movements through the 1970s. But of course, Medicare is a huge target, in part because of its redistribution function, in part because it keeps out the private insurance companies. They can't make profit from the system, and in part because it really did embrace and embody, for a long time, not-for-profit delivery of services. Pat Armstrong, who's a professor at York University, describes privatization this way. She says it is a downloading of care work from paid workers to unpaid, usually women in the home or volunteers. It's the download of payment from the collective to the individual, payment for healthcare services. It's the transfer of ownership and control from public or nonprofit ownership and control to private and for-profit ownership and control. And it's also copying of market modalities within the public health system itself or within the public service itself. And all of these things are now happening in our health system. So there is now a concerted attack on the public health system. I would say that Medicare in Canada, single-tier Medicare, has never been more at risk. There's a proliferation of private for-profit clinics across the country. Virtually all of them are selling two-tier healthcare in one way or another. In 5 provinces now, people can openly queue jump or buy access to services faster than everyone else. The prices of these services are far out of reach of most people. $2,000 for a cataract per eye, $26,000 for a hip or knee surgery, $5,000 for an arthroscopy, $1,000 for an MRI. In comparison, the median income in Ontario is something like $27,000 a year, so far out of the price range of most people. Although it's being sold as a solution to wait times for most of us, in fact, it's queue jumping for the wealthy, there's no question. And we've seen a proliferation of private for-profit, private US-funded think tanks in Canada that are pushing the message of dismantling Medicare. So, you know, Harper's think tank, forgot the name of it. No, the...
National Citizens Coalition.
What?
National Citizens Coalition?
Yeah, the National Citizens Coalition, which was formed actually to fight against the creation of Medicare in the first place. The Fraser Institute, which had a budget of $10.2 million, that's what they spent in 2006 on campaigns. They're one of their core campaigns to dismantle Medicare, but also attacks on income security programs. The Montreal Economic Institute, the Atlantic Institute, the Frontier Center, a real proliferation of them across the country. They are cross-pollinating, they work together. They have launched several court challenges, one, the Chiuli case, funded by the Canadian Constitution Foundation, which is funded partly from the US, from a set of right-wing foundations there, to bring down single-tier Medicare. And as Preston Manning counseled, you know, Preston Manning of his new think tank, the Institute on Democracy, they have kind of a consensus of opinion. Their goal, this is from Preston Manning at a Medicare conference in British Columbia, kind of the ground zero for privatization in Canada. He said, he counseled the delegates that they should present their ideas as a compromise, he said, between the extremes of the US healthcare system and the Canadian supporters of Medicare. He said, Canadians love compromise. Once the battle over language is won, then we'll be free to pursue our substantive prescription. Download taxing power to the provinces and let them do with Medicare as they please. At the end of the day, in Ontario now, we are seeing massive transfer of public and nonprofit assets, hospitals, long-term care facilities, to for-profit companies. Every round of health restructuring is accompanied with any new capacity being built in the private for-profit system. And within the public service itself, market modalities such as competitive bidding are being used. So that, for example, last week I spoke to a home care worker who told me that she worked, we calculated it, 67 hours in the previous 2 weeks, but had been paid only for 26 hours. Personal support workers in home care make $12.30 an hour approximately, but they're not paid for their travel time. In home care, a service that is intrinsically about nurses and personal support workers traveling out in greater and greater distances, they've regionalized healthcare, so there's 14 regions across the province, some of which are bigger than, you know, several European countries put together. These workers have to drive out and home, and they're only paid for the time that they actually make the visit. So these women are working for poverty level wages. They live in poverty while working more than full time in the public healthcare system. This is new. This is a new occurrence, and as we see hospitals privatized, as we see long-term care facilities privatized, as we see the public service itself privatized, the workers at the bottom, who are the ones who are always taking the crunch, you know, doctors' increases are going at 30% per year now. Nurses might be 8%, management in hospitals 10%, but the working class workers are running at inflation, and their numbers are being shrunk by attrition and so on. And many of them outside of hospitals are living at poverty level wages and are consistently the target of restructuring, trying to get more health care for less money. And so I just wanted to draw the picture for you. Medicare matters, public Medicare matters. It is a poverty issue to dismantle the large social transfers in this country, but it's also a poverty issue to allow the private for-profit transformation of our healthcare system, not just in ownership, but also in culture within the system. Thank you.
Okay, we're going to try.
That the kind of chaos and misery that's being spoken about, which is unquestionably the reality that's unfolding, reflects the fact that when we're talking about poverty in Toronto, we're not just talking about a removal of social provision. We're talking as well about areas of this city being contested. We're talking about a process of gentrification. And we're talking about people being forced out or people being warehoused in the most substandard and inadequate kind of settings. And people are living under conditions that are totally intolerable from the standpoint of their well-being, their health, and their dignity.
And those people certainly feel that enough is enough. And many people of goodwill around them feel that enough is enough. But the problem, I think, is that there is this prevailing sense that somehow we only have to formulate the appropriate, eloquent argument or put together the most poignant kind of brief possible. And somehow the politicians who just didn't get it are going to suddenly understand what needs to be done. I mean, in the case of the McGuinty government, we're dealing with a government that's been around for years now, and is talking, and it has the incredible ability to present itself as this false, this honest broker trying to deal with the complexities of this incredible poverty situation that needs to be studied as it's been studied for the last 200 years, and they're going to come up with the answer. That isn't the situation. The simple reality is that poverty is a political and economic agenda out of which a section of the population, a very small section of the population, is doing very well. And it isn't enough to say that enough is enough. We have to actually take that sentiment and turn it into something that isn't just simply trying to make moral arguments to governments, but is mobilising a movement that can actually compel governments to reverse the agenda, to provide for people's needs. When there's a sense that people have that sense of actually struggling, of resisting, that when there's a sense of social upsurge, that's when governments are going to move. And they're not going to move because we write a good letter to the editor. I'm not opposed to letters to the editor, but that's not the thing that's going to move them. It's going to be the sense that there is a population of people who have had enough of being oppressed and who are fighting back. And that's what we have to be dedicated to. And then we're going to talk about doing something about the conditions in Fred Victor and the conditions in people's lives, and then we're going to turn the situation around.
And demanding I don't know if you want the review on poverty, I'm not going to get into the demands because I don't know, but taking action on poverty. It is a ridiculous thing to say because there's an economic crisis. You can't deal with poverty. That is an absurd statement and you can't be allowed to get away with it. So why not link them both and mobilize, have both the anti-poverty, everyone concerned with poverty, housing, Medicare, and bring those issues together, putting pressure on the province. So I'll just throw that out. As an idea of using this date since it's already planned, and obviously there's an urgency to the issues that we're all feeling here, so I'll suggest that. Okay, no.
Yeah, couldn't agree more. I mean, we are the wealthiest generation in the history of the planet. In one of the wealthiest countries of the planet, there's no question that we can afford to provide for everybody if we chose to. The crisis is not of wealth, the crisis is really of greed. And so the question is, how do you extricate, that money, that power from the people who have seized it and quite effectively seized it? I think, which sort of brings me to a response to the question on democracy and voting. And although I appreciate some of what you're saying, I think I would take issue with the notion that social activism is useless and that really changing the voting system is going to make a big difference. I see the attack as much more broad and deep than a change of political party would necessarily fundamentally challenge. And I think that, but I do think, where I do totally support you, and the idea of what you're saying is that, to me, the antithesis of privatization is democracy, and every single one of our fights to protect the public health system and community ownership and control. We've had a major fight around democracy, around secrecy of information. Now they're wiping out the elected hospital boards. I mean, the local coalition in Sarnia, just so you know what people are doing, because nobody hears this stuff in Toronto, but the local coalition in Sarnia held a rally. 3,500 people came out to protest wiping out their Democratic Hospital Board. In Midland, they're fighting. They've held 2 massive town hall meetings, hundreds of people. There's only like 7,000 people in that town. Petitions. They're now busing to the protest to stop the wiping out of their Democratic Hospital Board. And same thing's happening in Alliston. The same thing happened in Scarborough to some extent, where 1,500 people came out, launched a court challenge to stop them wiping out their local hospital board. And that's just one level, and maybe it's a little bit superficial because those hospital boards never really were all that democratic anyway. But certainly, you know, setting a line and fighting like hell to stop them from taking away those things and making it as difficult as humanly possible to privatize inch by inch, surrounding the hospitals, stopping them from closing them, that's what we've found to be necessary to actually protect health services. And in Canada, you know, unlike all European countries now, and all industrialized countries, we still have maintained, at least by law, single-tier Medicare, and in part that's because we fought like hell about it, you know, every step of the way. That the healthcare movements are some of the largest movements in the country, that we fight for public opinion all day, every day, and we mobilize people en masse. And I think that massive mobilizing and you know, talking about what strategies work and tactics and having that discussion about how to actually win and how far you have to go to win is absolutely crucial for social movements at this time, because there's no question that all of us are losing ground significantly. Even the strongest social movements are in a defensive fight. Nobody's on the offensive at this point. There's no big gains out there happening anywhere. And if you were born after 1970, I mean, all you've seen your entire lifetime is heightening inequality, at least on an economic level in this country. That's very serious. And I think for us, I mean, what we've done that's worked, well, we fought the P3 hospitals, privatized hospitals. We held referendums in every town where they were bringing them. 80,000 people voted in referendums to stop the privatization of the hospitals. We didn't win, but we rolled them back from 34 to 12. In those 12, only a handful of jobs are privatized, maybe 4 or 5, whereas before it was hundreds, 400 or 500 per hospital. These are all big hospitals. You know, so significant rollbacks. And I think that when we're going to mount another campaign on it, we'll push hard again. On two-tier Medicare, you know, we've linked up with the coalitions across the country, and you know, in Alberta, where they actually tried to bring it in, they stormed the legislature. You know, all kinds of activities have happened. Now Quebec and BC are ground zero, and the campaigns have to step up there. But I just think we need to think about, there are effective social actions. They need to be bigger. They need to have more people in them. We need to organize en masse. We need cohesive organizing so you can make issues rise above the noise. And we need tactics that work.
Okay.
A question that has a lot of avenues that flow from it. I mean, the special diet was a special case in many ways, but it was a very, very important, perhaps the best example I've seen, because we actually had a situation where progressive-minded healthcare providers were in a position to actually ensure that we actually took an instalment of the things we were demanding. Precisely the point that Natalie made is that we have lived through a period of history, a long period of history, where primarily we've been fighting a rearguard action against a mounting agenda that has taken away from us. It's been a long time since we were really, in a true sense, on the offensive. We spend a lot of time, frankly, standing in front of legislatures demanding government to not do things that they're going to do anyway, etc., etc. For the first time, we were actually taking things from them. And for a while, they couldn't do anything about it. It was great. Not to say that the special diet was wiped out, because in actual fact, people's access to it, while many people have been hurt by their attempts to cut it, access to it has actually increased. They're actually now, in the city of Toronto, there's now, for people on welfare, there's an extra $30 million a year being spent on the special diet, because people have just found ways of getting it. But we are. It's actually gone up. The spending has gone up 20% in Toronto since they cut the program. So they didn't succeed. But there's a case in point. There's an acute need to find healthcare providers now who are interested in working on that very idea. There are a few providers throughout the city who are still looking to find ways to get the special diet to people. But that's a discussion that needs to be had, and it's a very, very urgent discussion. There's other practical and similar things that can be done. For example, there are masses of people in this province who need to get ODSP, who need to get disability, who need to get it, who should get it, under their criteria should be getting it, and are not getting it. And there's a real need for enlightened medical providers to organise to ensure that that those people actually get it, and then are backed up by movements and legal expertise to ensure that the barriers that are put up when people are diagnosed are met. And then there's the other great role, I think, of healthcare providers that is obvious and that some people now are organising around, and that is to use their medical knowledge to show precisely the social determinants of health, but not in some dry and academic way, but in a way that actually links up to political struggles to challenge poverty. As we go into the work that we're doing in Toronto community housing, in public housing, where they acknowledge they need to spend $300 million just to bring their housing up to a basic legal standard, where people are living in substandard hovels that are the shame of this city, while the police budget grows exponentially. In that situation, medical evidence and medical expertise showing the horrors, showing the medical consequences of the horrors that they're imposing on people would be of enormous importance. So I think we've only begun to scratch the surface of the practical ways in which people with medical knowledge, medical providers, can link up and actually play a key role in the struggle against poverty.
Thank you. I just want to say that, we've been talking about being in a certain period of time, and I would say that is starting to change. What's happening at Wall Street kills forever the argument that the private sector is more efficient and better at managing money than the public sector. What we have is now millionaire socialists who are asking for government money to bail them out. And I mean, I know it's good to make fun of them, because these are the same people who have argued that poor people should pull up their bootstraps, And meanwhile, these multi-billionaires are asking for money to be bailed out. So there's a big shift happening, and I think that we can use that to remobilize. And I think the point that was raised earlier, I just finished writing a book on new movements for social change, and the thing that I note in the stuff that I've seen is that where people are able to mobilize successfully is where they're putting forward alternatives, and not just asking the government for solutions, but saying, this is what needs to happen. We need this much money for social housing, we need that much, and we're going to start working to do some of this stuff and get people involved in actually solving problems, and not always just, there's a little different with defending Medicare, but not always just looking at the government to do that. And this is a real shift that's happened. I think it's a positive one. It's a little different than what I've supported in the past on the left, but it really mobilizes people for the same reason that the campaign that OCAP did mobilized people. Because not everybody, I've been out in Queen's Park about 400 times, not everybody is willing to go out to Queen's Park, but a lot of people are willing to work on constructive solutions to solve problems. And it's another way to mobilize people, as we saw with the food allowance, that wouldn't come out in the street in a million years, but would put their reputation on the line to actually directly help people in a campaign that solves the problems that we're facing. And so, and the other thing is actually mobilizing the people involved, like Toronto Housing. That's a big group of people there that have been involved in the participatory budget, and those people can be mobilized to come out in the street or do lots of other things. And they're all poor people. So anyway, that's just, I can't, me, I can't not talk, so that's my 2 cents. So I want to go back to the panel, and particularly back to Natalie or anyone else in the panel has something to say, and then we'll wind it up, because I know we got some really good ideas coming out of this, and I think the idea of working together is the most powerful idea, and that was the idea that we came in here with. So Natalie, do you want to sum up, or anybody? Yeah.
So Judy asked, and I think we absolutely agree that we should feature some speakers on the poverty issue at the rally on the weekend, and try in some more concrete ways, build those linkages. So that's one initial thing that we can do to start, and then we'll move from there.
I absolutely think that the health agenda and the social determinants of health agenda, being that poverty, being that homelessness, being that housing, being that even childcare needs to come together, and I also agree that it needs to be more on the streets and less on the classrooms.
And I just had one comment for the nursing student who asked about practical ways to talk about this stuff or to address poverty and health issues, I would work within your workplace. So when you actually start working, and especially in the more conservative workplaces like hospitals, talk to your colleagues. So you have to talk to nurses, other nurses, to other people who are working in the hospital about these issues, and sort of keep it alive, because it's a very easy environment to feel silenced because they are so conservative. But sort of find like-minded people. That's important, and where you're working, and just sort of keep those issues on the agenda and keep talking to people and do some education.
Well, I'd perhaps just say that since developments on Wall Street come up, it's clear that what is unfolding is a very serious crisis, the implications of which in terms of poverty, assault on healthcare are enormous. Because while a crisis like this does perhaps not bode well for people at the economic and political peak, at the same time it's important to bear in mind that they will always solve their crises at our expense if we allow them to. And in the period ahead, we may well be in for struggles that make the struggles we've had to date look like relatively minor skirmishes. So I think we need to realise that in the period ahead, McGuinty has already given us a little clue. The economy starts to turn down, and he seizes upon that as a pretext to say that poverty reduction must be put on hold. Quite the reverse. We will need in this period ahead the measures necessary to ensure that poverty is rolled back. And there's only one way to win that, and that is to socially mobilise and to fight for it. Thank you very much.
Okay, thanks everybody.